All right. Good evening, everyone. A warm welcome to you all to yet another exciting webinar brought to you by Blue Connect. My name, as you probably know it by now, is MMO-Squared. I am the administrator of this platform. Also to say a million thank you for taking time out of your busy schedule to attend this webinar out of the wake in the wake of what we're facing today as a country, together with the rest of the world. I know that the president is speaking today, so I really appreciate that people actually still found time whilst waiting for the president to speak to come and listen to this webinar. As this is a webinar, it depends largely on connectivity. Please expect some delays in transmission, so the voice might be ahead of the video or the video ahead of the voice or vice versa. Just a reminder that this is not a CPD session, but rather a thought-provoking talk, as I did say that we need to engage some of the challenges that are facing our profession. So from time to time, we'll have these talks, and we need to embrace and take ownership and start talking about the challenges that are facing us. Also to indicate that Mr. Naidoo, who's our presenter today, is here in his personal capacity and not behalf of any organization. So the views that he's going to present are his views. And also I would really urge you to say, limit your questions and comments to the topic at hand and not the organization that he is associated with. Now, as I said, because the president is speaking tonight, I'm going to skip some of the part that I always do, which is to tell you about what Blue Connect is about, and just go straight to the talk. And on that note, allow me to welcome Mr. Preggie Naidoo and to say thank you so much, sir, for agreeing to come and talk to us this evening and challenge our thoughts. And then let's start to initiate a debate on some of the challenges that are facing our profession. And on that note, over to you, sir.
Thank you very much, Mayor, and good evening to all our colleagues. And thank you for inviting me to share my views on telemedicine and artificial intelligence. Now, as you would know, I'm part of the ISOLISO executive and in full-time private practice. Now, as Mayoma has mentioned, I've been invited to the discussion in my private capacity, but I must acknowledge the African Vision Institute, Telemedicine and AI platform that is the brainchild of Steph Creel, who needs no introduction and is widely respected. Now, guys, kick back, put up your feet. You know, it's an unfortunate time in the world, but at least we've got the time to sit and have this chat and this discussion with each other. So I'm particularly bad with following slides and presentations, so I'll leave most of the reading to you. Now, you know, like you, I'm sure I've been yearning to get back to practice, to get back to diagnosing and treating. But before we get there, please consider this question. When asked why a patient would consult an optometrist, what if the answer is, I need to get my annual eye health screening done. And by the way, this includes a refraction. Please keep this in mind during the course of the presentation. So let's have some fun. So let us start by me giving you an opportunity to get the gray matter going again. Now, we've got a case where you've got a 61-year-old patient who has presented with right eye 20/30 vision, left eye 20/20, and he submitted retinal photographs and OCT scans via his optometrist to a panel. Now, if you look at the OCT scan, what we're looking at here on the right eye is a cystic macula, which explains the drop in acuity at 20/30. The left eye, retina looks fine, but you got vitreous issues. If you'd had looked at the retina with your ophthalmoscope, 90-diopter lens and so forth, you would have seen a clear retina, and you wouldn't have picked up what we're looking at now. So you will have realized that most would be challenged to interpret the scans that are presented. But now imagine a scenario where you could make sense of the information and use it to increase the potential and scope of your practice and this profession. This is called optometric intelligence. So let's have a look at the same patient and the optic nerve heads and the nerve fiber layer. You would see on the right eye, it's pretty normal. Left eye, there are significant issues with the thickness of the retinal nerve fiber layer, even though the acuity is 6.6. So how does the platform work? So you've got a platform where you've got specially trained optometrists, which is you and I, doing a refraction and doing effectively accumulating a host of data, making use of an African Vision Institute. I'll refer to it as AVI from this point on, using AVI specialist equipment, which is effectively a retinal camera and or an OCT. Remember, I'm saying either a retinal camera and an OCT if you have. And then you use customized software to submit the data. Now, you would examine the patient in your practice, accumulate the data, and then submit electronically to an AVI panel. In an ideal world, ladies and gentlemen, we should be doing this in a world going forward. If we're expanding the scope of our profession and our value, all patients should be having a wellness scan, which should be sent to a panel like AVI has. And this panel is composed of ophthalmologists. They would evaluate the data and generate a medical report. Now, at this step, the data that you've sent can either be sent, firstly, to an AI platform, artificial intelligence platform, that would then interrogate for a particular disease. So we speak either of glaucoma or diabetes at this point in time. If the AI report that comes back to AVI has identified cause for concern, that patient would then be flagged for further referral. That report that's generated is then captured on a national database, which is not evident at this point in time, and used in the future management of this patient. So the future management of this patient could include a host of modalities, including ophthalmology, neurology, and so forth. But you have a national database where requisite professionals would tie into to further manage that patient. Now, this is where the value comes back to us. The report generated from the AVI panel is then sent back to your practice, with a guideline in terms of how to manage the patient. So if a patient does not require further referral on to an ophthalmology practice and so forth, you would then be guided in terms of monitoring this patient over a period of time, regular follow-ups, until or if it's required at a point further on for further treatment. We're closing the loop and keeping the patient in your care. Now, the why. Why do we need AVI screening? Rather, the question that we should be asking is, do we need to change the way that we view our value, the way that we view our value as a profession? In South Africa, optometry is largely defined by refraction and little else in the eye care space. Telemedicine screening, I emphasize, allows for the early detection of pathology, treatment and monitoring, all from the comfort of your practice. This brings advanced tertiary overview to primary care at a fraction of the price. Remember, in an ideal world, all patients should undergo telemedicine screening as part of a comprehensive consultation. And, importantly, you and your practice is the hub of the technology and the report. So again, for the why in a little more detail, you can read this there's a whole host of information here. And if you look, they refer to a level 2 report and so forth. Now, let me just get this out of the way. Remember, I alluded to 2 levels of equipment at the practice, or 2 levels of of interrogation. The first one is using either a retinal camera for retinal photographs, which is a level 1 report. A level 2 report would have retinal photographs, as in level 1, but also include OCT scans. And this has the high sensitivity to detect asymptomatic disease, up to 96%. Now, this results in a highly improved level of care. There's no thumb sucking and gut feel anymore. It reduces costs and feedback. And also, in terms of co-management, you are intricately involved. Interesting fact. In the US, there was a study done. And, the study looked at how compliant were diabetic patients in terms of regular checkups. And they found that the compliance was 15% in terms of a routine checkup where patients were asked to come in. 15%. When telemedicine was introduced as an intervention, when telemedicine was used at optometric practices and so forth, the compliance was 71%. Why? Easily accessible at your neighborhood practice, low cost. The feedback to your practice will improve the standards of care for the patient and the scope of our profession. And importantly, we will develop and foster interprofessional relationships, which is pretty lacking at the moment. Again, I allude to the fact that the optometrist is the hub and remains responsible. This is a differentiation. The patient experience and your relationship with that patient is now enhanced. All of a sudden, you are the go-to guy. Referred patients are flagged to close the loop in AI. Now we talk about the primary eye care void. We're talking about the deep, dark, unknown. So, is there a need for care? Now, this slide talks about rather the 60, it's a bit messed up on this slide, but effectively, 64% of care occurs in public sector in this country. We've got less than 100 ophthalmologists in the public sector to take care of over 45 million people. In Limpopo, we understand, there's scant 5 ophthalmologists to take care of the population. That is scary and of concern. Now, if you look at the eye care priorities that have been identified by government, there are 4 general areas that need taking care of: refraction, cataracts, glaucoma, and diabetes. Where do we fall currently? Optometry effectively takes care of refraction and plays almost no role in 75% of the eye care needs of this country. 75%. It's an absolute open market for us to take part in and expand the scope of this profession. Now, in an environment where optometry needs to integrate with other professions in co-management, we need to ensure that we all work off the same electronic health record, which is standardized for eye care. I may be struck down by my thoughts, but this is what they are. We are possibly blinded by our failings as a profession. You may not like what I'm saying, but this is the fact. There is no national board exam. Medical professionals are quite taken aback when we tell them that. There's no respect. We're the only paramedical or medical profession that doesn't have this. How do we ensure that we can say with one voice that all our professionals, that we have one standardized level of care, that we all have the same clinical ability? We have lofty ambitions with the diagnostics and therapeutics. I've completed my therapeutic training at Groote Hospital. And let me tell you, I started 4 years ago. I probably finished 4 times over. But I can't stop because it's one of the most satisfying and most gratifying experiences. I was humbled the first day I got there, when I thought I knew a fair amount. And I'd seen more pathology in one day than I'd done in 10 years of practice. And I've been in practice for 32 years. There's no validated therapeutic training. The institutions that have started therapeutic training have done a wonderful job, really. I take my hat off to them. But we need a validated, centralized therapeutic way of doing things so that everybody comes out with a similar experience. We need to hold our heads up high and then move into the sectors that we are not treating. Importantly, the national public sector is largely ignored. We seem to exist in two different planes. Now, yeah, remember that telemedicine and AI are tools that allow you to improve the quality of diagnosis and follow-up in managing the patient over a period of time. This requires a shift in the way that optometrists are trained, such that we can be part of a medical care team. Optometry is dead. Long live optometry. When we divide the public from the private sector, it illustrates the massive market that we need to service. Currently, we largely service the private sector and have not found ways to bridge the gap between the two, in spite of the unquestionable need. I see opportunity. Opportunity for 3,000 optometrists and their private sector practices to offer primary eye care screening services via telemedicine and AI to the public sector. Imagine the invaluable data that our profession could present to government. Optometric intelligence, owned and managed by the profession. Makes it difficult to ignore optometry. Now, the eye care continuum, broadly speaking, currently patients are examined in our practices or in primary healthcare clinics and referred to ophthalmologists either in private or public sector for care. Now, during my internship at Groote, I noticed surprisingly that a significant number of patients were turning up at Groote with referrals that were effectively unnecessary or poorly based. And this flooded the system. If a telemedicine screening was conducted on all suspected cases prior to referral at marginal cost, this would save the patient unnecessary expense and improve the quality of the outcome. Importantly, those referred cases could be monitored using telemedicine at your practice on a regular basis with feedback to the treating ophthalmologist. Pick up your head, guys. The future is starting to brighten up. Now, who should provide care in this void? You've got the ophthalmic nurses who are not mentored appropriately in the tertiary facilities, with the result that their potentials are largely underdeveloped. Your undergraduate medical doctors only undergo between 2 to 4 weeks of clinical eye care exposure, and they're expected to be competent primary health care providers. Registrar ophthalmologists, of which in the public sector account to just about 100, take care of, like I said, of almost 45 million people. I have utmost respect for them. They are burdened by inappropriate referrals from GPs and optometrists when those guys need to train in their core skill, which is advanced surgery. Let's look at us. Well represented in the private sector, but only 200 odd in the public sector. It is time to leverage the potential of 3,000 private practices to assist in managing the national need. Telemedicine and AI allows us the opportunity to leapfrog this divide and buy us time to develop the clinical skills to meaningfully integrate into the national eye care delivery model. As an aside, where are we as a profession? Look at ophthalmology. Last year sometime, an amazing team at Care conducted the first transorbital surgery in the world. The first. And I've been working with some of these chaps, amazing people. They've leapfrogged the divide in ophthalmology to be at the cutting edge of technology and surgical skills. Why has optometry not moved ahead? There's a need. And like I said, unfortunately, these slides do tend to repeat themselves sometime, but let me just, you can read this, but effectively what I've said, you need the use of latest technology, inappropriate referrals. Let's start speaking to each other, primary and secondary care and tertiary care, an integrated eye care model. And we can all speak via an integrated platform. We prevent blindness via early detection. And we have a uniform reporting system. A national database is gold. And this we could be helping our country and our people. There's cost containment via this technology, and there's improved income for optometry. We hopefully, and we need to, not hopefully, we need to break past the 2-yearly examination cycle, because our scope of care now is not refraction. Well, not only refraction. So what's the AVI premise? It's based on, again, it's a conduit that combines the skills of optometrists and ophthalmologists. You send the report in, reviewed by ophthalmology, via a technology-driven platform, providing patients access to the highest levels of tertiary care at your primary care practice at a fraction of the cost. I've shown you the mechanism, just as a refresher. The benefits for the public, as I explained, is multifold. And we've got a national footprint. Currently, we estimate 600 retinal cameras and about 100 OCTs in optometry practices. Spectacle supply, we're not saying stop, please. This must now be synchronized with medical management. Increased compliance in diabetes, and importantly, this comes back to your practice. You would now be involved in second-tier patient education, ensure or improve compliance, and you would then be part of an improved outcome. You can read the details here, but effectively what I mentioned, you'd be doing in the AVI program, there are no shortcuts. You're doing a comprehensive optometry examination, which includes medical and optometric services, tonometry, refraction, AI report, either go to level 1, like I mentioned, and if required, you go to level 2 via the local ophthalmology review panel. The value add is important for optometry. You've now elevated optometry to beyond what it currently does. Now, this is important to understand. Some of you might be saying, this is not for me. This is just for those guys who want to do these fancy retinal photographs and OCTs. And the others may be saying, yes, I've got the stuff, and whoa, I'm going to differentiate my practice. Yes, you are. But you're not going to differentiate, or we are not going to differentiate the profession. Understand that we need a critical mass of practitioners, of optometrists, to be practicing at this level, this international level. It's not just unique to South Africa. We need to be at an international level to change the way our profession is perceived by the purchasing public and funders. Let's take an example here. You've got an AI report of a patient with mild diabetic retinopathy. Report goes through, comes back as positive, moderate diabetic retinopathy detected. This would now go to a level 2 report because you require the OCT scans to see any further damage. Based on the ETDRS guidelines, the AVI report will come through. The AVI report coming back to the practice, this is an example, would show, yes, confirm there's mild non-proliferative diabetic retinopathy But what do you do? The guidance says document and educate the patient. You need to do that. You will now become part of the care chain, not the GP, you. You would then communicate to the physician, and you would follow up in 12 months, depending on the extent of the lesions, and only you would be monitoring those lesions. You would not screen in these cases, but we've been trained. You know, the acute pain, acute redness, trauma, if there's a corneal ulcer, suspected RD, raised IOP with pain, you know that's the time to send off. And lid pathology or sudden vision loss. Ladies and gentlemen, I hope I haven't rushed through this. I mean, I tend to speak pretty fast, but and I hope I've gotten the gist through. Optometry needs to move to the next paradigm. And, you know, I think there's no better time to motivate for structural changes to start. And one of the tools or bridges must be an AVI type platform in its role of building public confidence with our patients, collaboration with ophthalmology that would lead to structured co-management, and offering the Department of Health an easy portal into mass screenings for people of this country, making us more relevant in playing a part in universal health. Professional skills and the fees associated must surely now break away from materials and this 2-year cycle. The aim must be at least 50% of turnover, professional fees that is. And this is where technology like the AVI platform play a role. You need to be less dependent on the sale of materials. That also means that we can keep it and compete, keep the supply of spectacles, but expand our scope and the profitability of our profession. We need buy-in from the institutions who need to be aware of the direction that we need to go. And together with the profession, we need to see what needs to be changed in the undergraduate training, not in 10 years, next year, and how we need to get the integrated model on a fast track to see that postgrad requirements are taken care of. And also, we need to find a way to upskill those of us who have qualified and now to bridge the gap to this level of care. Mayo and colleagues, thank you very, very much. I hope I haven't taken too much of your time.
Thank you so much, Preggy. This was something that is quite interesting, especially in light of what was presented last week, Tuesday, because it's quite in synergy with what was presented Tuesday.
Okay.
I have noted a couple of questions, and I'm just going to read them for you as indicated.
Sure.
The first one says, do we now need to buy OCTs in our practices?
I think that's an important question. Like I alluded to, there's level 1 and level 2 in terms of working with this platform. So level 1 would require a retinal camera, not an OCT. If you want to go to level 2 and invest in an OCT later on, that's your prerogative. You know, you can invest in it, and you could perhaps watch from the sideline by investing in a retinal camera. You're still going to get paid, and then as this technology expands and improves and becomes part of the delivery model, you then go to OCT.
Okay, thank you. The second one says, if we do send our patients to ophthalmologists for OCT scans, they do charge about 700 rands per patient. So I think maybe basically here the issue is the affordability. Any comments on that?
No, absolutely. Do you know, maybe if I may, I would suggest, if I may, that if there's sufficient interest in what I've presented, that you perhaps chat with Steph Creel and invite him to do a presentation on the AVI platform itself, the costings and so forth, and perhaps the community would get a better view in terms of where the fund flow would come. But the question is absolutely right. At ophthalmology level, you're paying 700 rand, but you're also paying 700 rand for the services for an ophthalmologist who is going to interpret the data that comes from the scans. At this moment in time, we haven't had the requisite training in optometry to base an absolute judgment on that. Therefore, we're getting tertiary overview from an ophthalmology panel here. Now, if I may just allude to the platform that has been tested. Now, we've been testing this platform for the last 3 years. Now, the platform has been in operation on our network, and for OCT scans, the optometrist is reimbursed at 180 Rand and about 100 Rand for retinal photographs. Now, it may seem like a little, but remember, this is the beginning. And the more medical funders that see the value in this, the more that come on, and the more value that optometry can add in interpreting that data, the more profit there is for optometry.
Okay, thank you. I see questions are coming in, and some of them are very controversial questions, but I'll keep on reading them. It says a lot hinges around acceptance of AVI with OSA, the cost of OCT, and what we as optometrists are able to charge. So I think it's more related to the first one, but I think maybe around the issue of OSA. Any comments on that?
No, absolutely. Look, OSA is an organization very much like the SAOA. So we are not beholden to any other party with respect to using OCTs. It's within our scope, and we're free to use them at will. But we need to use them in a responsible manner to ensure that the outcome is validated. So we don't have to ask OSA, for permission to use OCTs. We're doing this in a responsible manner together with ophthalmologists. So I see scant reason why OSA would take exception to this.
Okay, thank you. Then the next one says there are people doing MSc in investigative ophthalmology, thus allowing them to practice at similar levels as ophthalmologists. In view of this development, would you advocate for their recognition at a different level by the registrar at the HPCSA, of course, with due diligence done in terms of content covered?
Sorry, if I understand that correctly, are you talking about a Master of Science, or are you talking about
a Master of Science in Investigative Ophthalmology? I believe this is an international qualification.
Now, I do understand in South Africa that there is a diploma in ophthalmology, that a GP who's part of the public healthcare system can apply for and study. It takes about 6 months, if I speak under correction, and they would then be qualified to do cataract surgery. Now, that's within, strangely enough, that's within the public health, that one.
Yeah, so basically I'm just administrating these things. So when I come on behalf of the HPCSA, maybe some of the questions related to the HPCSA, I will be able to take those questions. But for now, I think we'll leave it at that. The next one says, Mr. Naidoo, would you advise on the patient confidentially? Let me start that again. Mr. Naidoo, could you advise on patient confidentiality considerations? Can patient data be anonymized? Also, is there currently an appropriate electronic health record system suitable for this? Which AI software is being used, and are ophthalmologists currently involved, or is this a vision of what could be? And it ends by saying thanks for the presentation.
Sure, thank you. The question is absolutely relevant. One of the things that Steph, that's why I say, please, I'd urge you to invite Steph to come on and give you the detail on this. As part of the AI platform that the African Vision Institute is running, there's a confidentiality, confidentiality walls or firewalls all through the system. The first part of this is that no patient can be included in this without signing a confidentiality document and allowing us to transmit their data for further interrogation by the panel of ophthalmologists. And that runs through the entire channel of care. So, one of the key aspects in this particular product is to ensure that that data is safe and secure and protects the patient. Sorry, the second part of the question was which AI platforms are being interrogated. One is the IDX platform, and there's 2 or 3 others that Steph has interrogated with. In fact, we are almost ready to run a test bed on one from Sweden. Now, further detail was supposed to have been shared with the entire community throughout the country, with a roadshow that should have started at the end of April. But as you all aware, that because of the COVID lockdown, all of this has come to a total standstill. But this is a brilliant opportunity for us to share this and take perhaps a deep or require further understanding of those platforms and the technology that lies behind them in a further discussion. But yes, we've examined. In fact, there's only one platform, if I understand clearly, it's IDDX platform that's got FDA approval in the US. But there are others across the world. So, we don't have to, follow FDA approval, but it's something to respect. And the interesting part of AI is that currently, it's very disease specific. And there are two diseases at the moment that they've got running platforms. One is glaucoma and the other is diabetes. It's not for everything.
Okay, thank you. So the next one is simply asking, so is the diagnosis going to be made by a computer?
No. If you upload your photographs to the system and the system then sends firstly off to the AI platform, the AI platform purely generates a screening report. That is not a diagnosis. That's a screening report. That screening report is, this is interesting. The screening report is received back to the AVI office within a minute. So that would just highlight if there are areas of concern, which would then guide whether it requires further interrogation by ophthalmology or any other requisite professional group.
Okay, thank you. There's an interesting question here. It says, but Preggy, the biggest problem is that networks and managed care organizations negotiate price on the basis of costs of spectacles and not clinical care. And the question then goes on further to say that you find that in some instances, optometrists are paid for funders photography only if there is positive pathology. Is there any comment on that?
No, in fact, that's a brilliant question. Sorry, I love that question. Do you know why? It tells us exactly where we are at the moment. We're stuck in the spectacle paradigm where everything we do is relative to a pair of spectacles and an eye test, and then we've got to plug these medical so-called things onto an examination, and this is where the question again, which comes first, the chicken or the egg? So we've got to prove to the medical funders that we've gone beyond just providing a pair of spectacles, and if we do this well enough, we can change the benefit design. The person asking the question is absolutely right, because the risk benefits are profiled on a pair of lenses, a frame, and a consultation currently. Now we're tacking on something that's an AI or a telemedicine initiative. We should have been the other way around. Telemedicine and AI first, and spectacles as an adjunct if required. So this is going to be an interesting path, and again I say, we've had some interesting discussions with funders who look at us askew and say, so you guys can do this? I go, all right, okay. And then the other question is from funders is, okay, so how is this going to benefit me? And this is where we've shown that the downstream costs to the medical scheme could be significantly reduced by early intervention. So, for example, if we pick up a diabetic early in the system, and treatment is initiated at whichever level by whichever provider, whether it's a medical doctor or a physician and so forth, it prevents more serious damage further down the line and saves the scheme money because they don't need to hospitalize this patient, or they wouldn't need to put in such intensive medical procedures that's at serious cost. So again, we need to be running this kind of proof of test as a profession. We need to draw with this database. Let's start the conversation. So where do we start? And then when we have a proof of concept, we take it to the funders, where we take it to the other professions, most importantly, and say, chaps, this is what we can do, and here's the proof. Now let's change the benefit design, and let's take this 2-year thing out.
Okay.
2 years for losses, yes, but for medical interventions, no.
All right. Thank you so much for that. I see that other two questions you've already covered on that. The other one was on ophthalmologist, and the other one was asking about the platform. But I think maybe I'll just read the second part of this one. Says, where can we send our funders photos and OCT scans? I think this will be covered by Steph Krill as and when we invite him. Am I right?
Absolutely. Yes.
Okay. So the next one says, is this going to be possible in the public sector where buying of equipment is a problem?
Now, here's an interesting one. When we talk about, we're not talking about doing this in the public sector. What I was talking about is this. Remember, if we've got 3,000 optometrists, and currently we have 600 odd with retinal cameras, we got 100 with OCTs. Let's start with the 600 with retinal cameras. And we ask the public sector to send those patients in to us. Let's talk about your local clinic, your day clinic, your day hospital, and so forth, who screen the patients and they pick up pathology and they don't know what to do with this thing. And then they would send it down to a hospital that's log jammed. And they can't triage the patient with respect to optometry, ophthalmology, because they don't have the skill sets. Yet your local optometrist has got the platform to triage effectively with telemedicine, identify whether it's an urgent or not referral, or whether it can be managed in his office. That cuts the cost. So your practice, your infrastructure is then being used for national good. If we're going to ask the national government to put in OCTs, retinal cameras, and the rest in those clinics, it brings a host of infrastructure issues that I don't think we should be looking at. We should be looking at bringing optometry to the masses using our current infrastructure, which is our practices.
Okay. The next one says, good evening, I have a question. I'm all for a standardized record card. In fact, I have an electronic card system. If we centralize the database, who controls it? In the 21st century, data is king, and surely that data will be sold off. How are we as optometrists going to benefit when this data gets sold? We are the ones putting in the time and effort to collect the information.
Absolutely. I mean, that's one of the scariest things, and I think there we need to be mindful. In this kind of situation where we've been working with AVI as a partner network, whatever, to test bed their platform and so forth, one of the key areas is that all the electronic data is not held by the network, it's held by AVI, and they take sole responsibility for that and ownership. Now, importantly, as part of the agreement that we have with AVI is that all the information is sacrosanct and cannot be sold further on. I think that conversation needs to be taken further as a profession with African Vision Institute and the like, in terms of how do we need to ensure that that data is not used for the advantage of any particular group, individual, or institution. That's a way to start in the conversation. A very, very, very important point.
Okay. There is another one. Why is the pre-sequit training not compulsory if it's truly going to benefit the profession? I think it's supposed to be prerequisite training.
Yeah.
I'm not sure what this guy is trying to say here. Maybe if you can just help us by retyping the question, then I can be able to read. I thought it was me who couldn't read this way.
So he's asking, why is the prerequisite training not included to benefit the profession?
Oh, yes. Okay,
now fantastic. I think that's a great question, because one of my pet peeves is this. Like I said, we need to start speaking. We need to start speaking to the training institutions, and we need to sit down together as a profession and ask ourselves. And I alluded to when my personal experience, I've done everything up to the OD didactic level, and I thought I was pretty knowledgeable until I got to Krutiski for the first day. And I encourage, I beg you guys, I will even try to arrange this. I'll take groups of our colleagues. Those in the Western Cape, speak to me. I'll arrange a day to take you to Krutiski, to the OTP, to the outpatients department. And you'll see firsthand what I'm speaking about. The level of pathology, the way to interact and identify and work with it is on a level we have never seen before. Our colleagues who work in the public sector, I take my hat off to them. Those guys are at another level in terms of clinical and pathology training. Now, we need to look at the way we're structuring our training for the future optometrists. We need to find a way to train the optometrists who are qualified, like you, I, and the rest of us listening here today, to bring us up to a level where we can interact meaningfully at this level. And it can be done. It can be done. I mean, in my case, I can't stop going to risk. I'm nuts. I go there no pay, and I'm what do they call me? I'm some funny term they use where I get no pay, but I work there once, twice a week in the mornings, and I see 40 patients, pathology. It's absolutely stimulating. It's on a level second to none, and I'm addicted to it because it keeps my clinical skills as sharp as can be. But the question is right. We need to look at, and seriously, how do we bridge this gap in terms of clinical skills? Telemedicine right now, and this is important, if I may just stretch this point, very important point. Right now, if you're taking retinal photographs and you're taking OCT scans, and you're sending them via the platform up to a panel of ophthalmologists, you are nothing more than a glorified technician. Remember that. And there are dangers inherent in being a glorified technician because you and I can be replaced. The importance and the value of this initiative is to buy us time such that we bring ourselves to a clinical level where we don't need further interaction. We can grade in our practices, we can interpret meaningfully, and we're comfortable in our diagnoses. That's at OD level, if I may just use a loose term, and we can get there. The rest of the world is there.
Okay, thank you. The next one, I'm struggling to make sense of this question, but I'm going to read it other way. With regards to ethics and legal issues, which managing healthcare practitioners is responsible, should a complaint be lodged with HPCSA, the AVI specialist or optometrist for what in misdiagnosis or misdiagnosis? That's what I'm saying. I'm struggling to read.
Okay, no, but okay. Ultimately, the managing practitioner, that's the optometrist, would be responsible, and the buck stops at the optometrist. So the optometrist who's using whichever tool, whether it's AVI, whether it's whatever channel, to get further depth in terms of handling the patient better, takes clinical responsibility in terms of handling his patient. So if even using an AVI platform, or let's use the word a telemedicine platform, and you get feedback that says, chap, you should be doing this, you would then need to exercise your ultimate clinical judgment, because it's feeding back to you and assisting you to make a judgment. It's not a definitive.
Okay. I have a follow-up question from the question on networks and the funding model.
Sure.
It says, even before AI is made a factor, there has never been a willingness to advocate for clinical aspect of optometry. I mean, AI is not a gold standard for optometry, but dilated fundus examination is something that we can all do. But there is no network that can raise a hand to say medical schemes, to medical schemes that they must pay for such procedure. It is all to do with price options by MCOs. Any comments on that?
Well, I'll tell you what, do you know, when it comes to the pricing and the rest of it, again, like I said, we can only start requesting payment for procedures if we can prove that we're doing this on a global level and the outcome is to the benefit of the member and the scheme. So, I'm all for including further benefits to the including more procedures to a benefit structure, provided we can convince the funder, that's the purchaser, that we're adding value to that member and to the scheme in terms of cost containment. But I think it's dangerous to start with the money first and then designing a clinical intervention to suit the money. Let's get the best possible clinical intervention, show why it works, and then ask for the money. Then we got something to stand behind.
Okay. Then the next one, I think it's a comment from Sanet, who says that, yes, please, I would definitely like to visit Grooteski Hospital. And there's an email address which I will forward to you, Preggy.
Lovely.
The next one says, I assist an ophthalmologist in private care and can relate to the side whereby you say many referrals were necessary. Our optoms don't have the confidence a lot of time. We also are scared of legal consequences. It is erring on the side of caution mostly with our training here in South Africa. Any comments on that?
I couldn't agree more. I think I've been working with Dr. Hamza Mustak. He's quite a highly regarded ophthalmologist in the country. He was one of the guys in that team doing endoscopic surgery where they removed the tumor at the back of using the orbit. And he's of the view that and that optometry is a highly under-resourced skill, or you are underutilized skill in this country. And he says, Preggy says, he's a critic, he says, they did a study in terms of the referrals that were coming through to the outpatients department. And he said, the GPs, the greatest respect out there, he says, their referrals were all over the place, absolutely, without basis. He says, optometrists, 80% of the time were on the head. They had identified there was something wrong that merited intervention, but often they weren't comfortable enough to stand on the spot and say, this is what it is. So the opportunity comes here. Now, this is important in the fact that if we training and honing our clinical skills in a public sector environment while we're assisting at a Groote Schuur, we're assisting at a Paragon, you doing this under the protection of that institution. So you can assist in there under the guidance of a team, ophthalmology team as it may, and you can hone those skills until we have built a sufficient cohort of practitioners in our country to move this training up. And, again, I say, it's time to start these conversations with each other. And these are serious conversations and that require significant work from all of us. Let's put down the retinoscopes and say, Caps, we need to look further than this now. How do we study further? How do we train those skills? It's not just picking up a book and passing it at 80%. Now it's practicing the stuff, and it can be done.
Okay. I think this will be the last question. It says, please advise what happens to all of this when and if NHI kicks in.
I think that's NHI is not up for debate if it's going to happen. It's when and how, in what form. Now, let me answer that question with another question, which is not right, but let's just look at it. Right now, the government has a great wish list, and that wish list includes a whole lot of primary care interventions for an NHI scenario. The pile of money is really limited. So they've got to cherry pick which they're going to do first. And optometry right now doesn't seem to be the top of the pile, but it's easy hanging fruit. It's an easy one to do. But we need to be part of the way we design the way that optometry interacts at this level. Now, imagine an NHI scenario where 3,000 optometrists out there with the delegated entry points in terms of identification of disease and refractive error. But importantly, identification of disease. And these are the diseases that sweep through all segments of society. And NHI would lap this up. But the important part is, government doesn't have the time and the manpower to go out and invent the solution. We can. This is our territory. This is what we do. So we should be inventing the solution and take the solution to a government that's largely going to be quite grateful because we've done the work. So NHI is the opportunity. That's the way I see it.
Right. I think I see some comments here. Just the last comment. It's not really a question. It says the challenge is that we came out of varsity and found a better one or better two optometry world. We need to redo a lot of work that we were taught at varsity. I think that was just mainly a comment, and I don't know if you have to just comment on that.
No, I can't but agree. Absolutely.
Okay. All right. Okay. I see people are still asking questions. Maybe let's just take one extra.
Okay.
People are hungry for this thing. This one says, please clarify, did you say MBCHP does the eye for 2 weeks only in their scope, and we do it for 4 years? They still
Absolutely.
qualify to prescribe other schedules of eye drops.
Yeah, you got it right. You know, the fifth year students at Grooteskier come in and do their rotations in the eye care clinic, in the OTP, in the outpatients department, sorry. And that's exactly what those poor kids do. And you know, they're taught to identify gross red eye. They can't measure IOP, so they wouldn't even know that unless there's an acute angle closure incident. That's about it. And you know, red eye is red eye, and they get the host of drugs to manage and treat. They don't have the equipment to do further testing. They wouldn't be able to identify the type of keratitis, or if there was a corneal ulcer. So you know, understandably, they're trained to be private healthcare practitioners. They can schedule up to whatever, but they don't have the requisite skills. Now, again, the report from Grooteskier said unequivocally the referrals from GPs were highly questionable, whereas the ones from Optoms were on the button.
Okay. The others are comments are people who want to visit the Grooteskier hospital with you. I've taken down the email addresses, and I'm going to send you the emails. And I have one here where someone is asking for your email. Would you be able to share that?
Yes, it's Preggie, Preggie, at isoliso.co.za.
Okay. Thank you. I think that is it in terms of questions and comments. Colleagues, I would like to first thank you so much for your time. We did say that we'll take about an hour, and I see that it's almost 7 o'clock, and I wouldn't want us to pass that. I sincerely would like to express our gratitude to you, Preggy, for taking time to come and share it with us, this interesting topic. We really appreciate it as the platform Blue Connect. Thank you so much. Colleagues, just to remind you that tomorrow we have a CPD session titled Specialty and Therapeutic Contact Lenses. It will be happening at 10 o'clock, so please do register. I think the link is circulating on our Facebook page, on our Twitter, and in some of the WhatsApp groups, and also on email. If you have registered for one of our CPD or webinars, you should have received an email about that. Next week, we will bring you the HPCSA. We will be joined by the acting registrar of the HPCSA to talk about some of the what do you call this, unprofessional conduct under the Health Professions Act. And I think some of the questions that you had and comments on the HPCSA would be best suited for that session next week. And also to say that those of you who have attended our CPD sessions, you should have started receiving your CPD certificates today. We are using a bulk mailing system, so probably you will receive them later tonight or tomorrow. So give it up until Thursday. If you don't see anything, please drop us an email on cpd@blueconnect.co.za, and then we will email you your certificate. And on that note, I just want to say thank you so much again, Mr. Preggie Naidoo. Any last comments from your side?
I don't. Thank you. I really must thank you. I think this is a brilliant opportunity, guys. Let's start the conversation. And those guys who want to visit Grooteskier, let me tell you something. Those registrars and the key guys there are going to grin from ear to ear. So let's take this forward. Thank you so much. Have a good evening.
Okay. Thank you so much. Have a good evening, everyone, and then enjoy the rest of the lockdown. Thank you. The webinar will now be closed.